HPB, and today we are going to discuss some important topics related to general surgery. All the sessions are being streamed live, and they are also being recorded and being uploaded on the website of Mahatma Gandhi University of Medical Sciences and Technology, the MGUMST YouTube channel. They are also being uploaded on the YouTube channel of Gastro University, which hosts the weekly Jaipur surgical tutorial. And I'm very happy to inform that on both these portals, the number of views of day one and day two have already run into more than combined more than 700 to 800 for each day. Uh, so I will now request Dr. Prekshit Chhaparwal, who is the session coordinator, to start the proceeding.
Good morning, everyone. So today we have sessions about the general surgery part of the conference. For the first lecture, we have Mr. Jitendra, Dr. Jitendra Chawla. Sir was the zonal vice president for HSI West Zone. He's also the founder president for the Rajasthan Hernia Society. He's currently the director of general and minimal access surgery at Fortis Escorts, Jaipur. He's been eminent about the hernia surgeries in the state and the country as well. I request Dr. Jitendra Chawla to take the lecture forward on the topic for for the lecture is surgical anatomy of groin hernia repair, open versus laparoscopic.
And Dr. Shireesh would
We
be.
have two discussers as well, Dr. Abadhesh Sharma and Dr. Shireesh Gupta. Sir is a professor and unit head at Mahatma Gandhi Medical College. Sir has been my mentor as well.
Thank you, Prekshit, for the kind introduction. At the outset, I thank Dr. V.K. Kapoor, sir, and the management of Mahatma Gandhi University of Medical Sciences. Uh, we had a wonderful keynote address on the anatomy, how and why it is important for the surgeon by Dr. Shastri. That was a wonderful lecture. I think all must have listened to that, and he has highlighted the importance of anatomy in surgical fields. So let's continue with that importance. That no disease of the human anatomy, human body belonging to the province of the surgeon requires in its treatment a better combination of accurate anatomical knowledge with surgical skill than hernia its all its variants. It was said by Dr. Cooper 2 centuries ago. That is still relevant today, not only in hernia, in all kinds of surgery. How will it continue?
देखिए
आगे
स्लाइड मूव नहीं हो रहा है.
नहीं होगा. So वहीं से हो जाएगा. So I bring my greetings from the Fortis Hospital, Jaipur, to all of you. What why we need importance of anatomy in surgical fields is we want to do a safe surgery, not only for the patients, for surgeons as well. So goals of hernia repair is primary goal is the prevention of recurrence, and secondary there are secondary goals also. We should aim for low morbidity like pain or discomfort, faster recovery in today's era, especially in today's modern era of limited time with the patients, improved function and regaining contour, especially in the ventral hernias. So and it should be cost effective also. So let's go back to our anatomy days. In the first year of the MBBS, we all have been gone through. So inguinal canal, when we are discussing about the inguinal hernia or groin hernia, we should know the anatomy of both the fields, as well open as well as the endoscopic anatomy. So inguinal canal is a 4 centimeter long canal which traverses from deep ring to superficial ring. Deep ring is at the mid inguinal point. We all know it, and superficial eh, external ring is just superior to the pubic tubercle, just lateral to the pubic tubercle in the midline. And boundaries are interior boundaries, external oblique aponeurosis plus internal oblique muscle on the lateral one-third aspect. And posteriorly, it is mainly formed by the transversalis fascia and conjoint tendon formed by the transverse abdominis and internal oblique at the medial tooth. Roof is formed by the arced fibers of internal oblique and transverse abdominis. Floor is formed by the inguinal ligament, that is a rolled up external oblique aponeurosis. Contents in the male patients, it is spermatic consists formed by vas deferens and testicular vessels and nerves. In females, it is round ligament and the ilioinguinal nerve and genital branch of genitofemoral nerve. Ilioinguinal nerve doesn't pass through the deep ring. It pierces the muscular part of the canal and traverses only the canal only. When we come to the lap hernia repair, what is the issues? What are the issues? Because it's a new anatomy, new perspective. The main issue is the understanding the anatomy first and training and learning curve. And there are so many issues, other sterilization, infection, part and anesthesia, because laparoscopic surgery you need to do under GA only. So groin has an unique functional composite of musculoskeletal, visceral, and neurovascular components, which provides a dynamic physiological integrity of the region. The breakdown of this integrity produces the hernia formation. So understanding the anatomy of groin plays a pivotal role in laparoscopic hernia repair surgery to prevent the complications like recurrence or pain or discomfort, because laparoscopic view of the groin is quite different. We need to learn, unlearn, and relearn. Dr. Shastri has mentioned that anatomy is a dynamic, it's not a static this thing. So laparoscopic perspectives for the groin, because it has a long learning curve in laparoscopic hernia surgery because of complex anatomy of the posterior aspect of groin. Most of the surgeons are unfamiliar because they are being used to do open surgeries. So the description and orientation starts with the innermost aspect, that is peritoneum, and proceeds outwards towards the skin. So let's start with the peritoneal landmarks. Whenever we enter into the abdominal cavity, we shift our camera towards the groin region. We need to identify peritoneal landmarks. There are 3 types of peritoneal folds or ligaments and 3 types of fossa. These fossa delineate the sites of groin herniation. They are essential landmark for the orientation during surgery. So we need to identify these structures. Like median umbilical ligament is the first, which is a bit, sometimes you cannot see in this, but it is in the midline raised by the urachus, extends from the apex of the urinary bladder to the umbilicus. Then there is a medial umbilical ligament, which is raised by obliterator umbilical artery. This is the most prominent umbilical this ligament, traced downwards towards the internal iliac artery. And then there is a lateral umbilical ligament, which is raised by the inferior epigastric vessel, which is also very important. You may not find very clearly in some thin patients, but divides groin space into the space of Ridgius medially and space of Bogros laterally. We'll come to that later on. And then there are 3 infraumbilical fossas. Supravesical fossa, that is between the median and medial umbilical ligament, which is the site for supravesical hernia. Medial umbilical fossa, that is between medial and lateral umbilical ligament. That is the site for femoral and direct inguinal hernias. And then there is a lateral umbilical fossa, which is lateral to the inferior umbilical ligament. Inferior epigastric arteries, that is lateral umbilical ligament. This is the site for indirect inguinal hernia. So what we do in laparoscopic hernia repair, whatever procedure we do, TAPP or TEP or ETAP, we need to go into pre-peritoneal space. If we are going through the TAPP approach, we have to reflect the peritoneum, raise the flaps, and then there are landmarks which are in front of us after peritoneal reflection. These are very important landmarks. First, most important landmark is the inferior epigastric vessels. Then there is internal ring, quad structures, pubic symphysis, and pubic ramus. iliopubic tract, and Cooper's ligament. These are the landmarks which we need to identify, we need to understand. And this is the laparoscopic view pictorial. The picture A depicts the intact peritoneum. So this is the first landmark we go into. We're going to see the inferior epigastric vessels. Lateral to this is slow, is site for indirect hernia, and medial to this is the site for direct hernias. And below that, this is the vas deferens turning medially and gonadal vessels going laterally and upwards. And this is the medial umbilical ligament, which is the most prominent ligament when we see through the peritoneum. When we go to this same area after the reflecting the peritoneum, these are the structures, same inferior epigastric, vas, gonadal vessels, and this. So let's come to see the video, these things. So this is the inferior vas deferens turning medially, gonadal vessels literally, inferior epigastric vessel going upwards toward rectus muscle. This is the site medial to the inferior epigastric site for direct, and lateral is indirect. This is the medial umbilical ligament, which is the most prominent. This is the site for median. And this is the normal anatomy on the left side, medial. And then there are again vas and gonadal vessels. So when we reflect, we go to the preperitoneal space, which is the most important space, which is the mandatory space we have to dissect when we are going to embark on laparoscopic hernia repair. It's crucial to the laparoscopic surgeon. All laparoscopic approaches, we have to go into this space, whether we do TAPP, TEP, or ETAP. So when we reflect the peritoneum or we go into preperitoneal space, the most important structure is the transversalis fascia, involved in the development as well as the repair in the hernia. It's a bilaminar layer, anterior strong layer and posterior membranous layer. Posterior layer develops the space, divides the space into two departments. Anterior parietal, that is a vascular space. That means there is a high vascularity between the two layers of lamina, transversalis fascia. And posterior visceral layer, there is a space of Bogros. That is the working space for laparoscopy surgeon. That is on the lateral aspect and continues medially with the space of Ridgius. Space of Bogros is a retroinguinal space. That is a preperitoneal space situated deep to the inguinal ligament, extends from inferior epigastric vessels laterally to the anterior superior iliac spine. It communicates with the space of Ridgius medially, divide into two compartments, divided into two compartments, that is medial, that is which contains the femoral vessels, and laterally there is iliopsoas and the femoral nerve. It is bounded by anteriorly by the fascia transversalis, and posteriorly bound. Original description it was described by Bogros was psoas muscle, external iliac vessels, and femoral nerve. Lateral boundary is the pelvic wall, and medial is the inferior epigastric vessel. It is continuous medially with the space of Ridgius, that is a retropubic space or the prevesical space. We call it cave of Ridgius also. It's posterior to the pubic symphysis and anterior to the urinary bladder. The space of Bogros and space of Ridgius are working space in the laparoscopic hernia repair. For the proper placement of mesh, you need to decide both these spaces very well. So now we come to the derivatives of transversalis fascia, which are iliopubic tract, Cooper's ligament, internal ring, and femoral sheath. These are important landmarks. Iliopubic tract runs from the ASIS, anterior superior iliac spine, to the pubic ramus medially. It's parallel to medial inguinal ligament. What we see in the open hernia repair is the inguinal ligament. What we see in the posterior repair, that is the iliopubic tract. It's a most important landmark which divides the space into upper, superior, and inferior aspect, and which divides the space into medial space of Bogros and lateral into a space of Ridgius. It forms the superior boundary of triangle of pain, which will come later on. So there should not be any fixation below this iliopubic tract. Cooper's ligament is a shiny fibrous structure that covers the superior pubic ramus. This is the structure when we go into the medial fossa, medial space, while dissecting for the laparoscopic hernia repair. This is the structure we should see first. That is called space of Ridgius. Is this supravesical space, what we call is a lighthouse or the White House of the hernia surgery. It's a condensation of periosteum, fibers of inguinal ligament, iliopubic tract. It's a tough structure, shiny, provides suitable area for mesh fixation also. And then there is a lacunar ligament, which is formed the medial boundary of femoral ring. Femoral ring is the site for femoral hernia, just below the iliopubic tract and between this Cooper's ligament. Apex is formed by the pubic tubercle. Posterior aspect is the patinal line of the ligament, and anterior is the inguinal ligament. So this is the site for lacunar ligament, and this is the site for femoral hernia. Just medial to the inferior epigastric vessel, below the iliopubic tract, and above iliopubic tract is the site for direct hernia. This is the Hazelbeck triangle.
5 more minutes, Dr. Chawla.
So this is Hazelbeck triangle formed by the inferior epigastric vessel on the lateral aspect, medial aspect formed by rectus sheath, and inferiorly this is a Cooper's ligament. It is the site for direct inguinal hernia and the femoral hernia. And then there is a concept of myopectineal orifice. Dr. Frouchard has raised this, come up with the concept that all groin hernia occur in a weak common area. That is myopectineal orifice. Superiorly, it is formed by the internal oblique and transversus muscle. Inferiorly, superior pubic ramus. Medially, rectus muscle sheath, and laterally by the iliopsoas muscle. These are the vessels in groin region. We have already discussed about external iliac vessels, and inferior epigastric and testicular vessels are the most common vessels, arteries and veins. And corona mortis. It's an aberrant obturator artery which forms a communication between epigastric and obturator vessel that passes over the Cooper's ligament, pectineal ligament. We have to take care of while dissecting the space of Ridgius or while fixing the mesh, because it produces torrential bleeding if injured. And these are the nerves in the groin region, which are more important. Our nerves are the lateral femoral cutaneous nerve of the thigh on the lateral aspect, femoral branch of genitofemoral nerve. Genital branch is going into the open area, open inguinal canal, and anterior branch of femoral nerve. And there are 3 nerves which are not in danger: ilioinguinal, iliohypogastric, and genital branch of genitofemoral. These are in danger in open hernia repairs. These are the triangles of doom, which we need to understand, formed by the vas deferens medially, gonadal vessels laterally, and the peritoneal reflection on the inferior aspect. And then there is a triangle of pain, which is formed by the gonadal vessels on the medial aspect, iliopubic tract on the superior, and lateral aspect, the lateral inferior aspect is the reflected peritoneum. These are the triangles of groin, which has a different sides for hernia. This is direct, this is femoral, this is indirect. These are the inferior epigastric vessels, triangle of doom and triangle of pain, 5 triangles. Then there is a concept of critical view of myopectineal orifice. We need to dissect the critical view of myopectineal orifice. we need to dissect this area before putting the mesh in the laparoscopic hernia repair. That's the most crucial aspect. It extends from the 2 centimeter beyond the opposite side till the uh, anterior superior iliac spine and well above the corpus ligament and pubic symphysis superiorly and at least 2 to 3 centimeter below the pubic bone. बहुत स्लो चल रहा है वीडियो यहाँ तो सही चल रहा है. And these are the 12 landmarks we have already discussed. And this is a video short clip of
You can take 5 more.
laparoscopic hernia repair on the right side. That is a TAPP. After slow motion में जा रहा है. After identifying that it is an indirect sac, we need to mark the peritoneum marks, saving the inferior epigastric vessels. Then we go into the medial aspect. After raising the peritoneal flaps, first structure we see while dissecting in the that we have gone into the space of Ridgius. And now we go into the lateral aspect. We create a lateral fossa, that is zone 2, we call it. We dissect till anterior superior iliac spine, then we go into the target zone, that is a hernial sac. We keep on dissecting the hernial sac from the from the cord structures. When we see a bluish discoloration, bluish tinge of this is the area when we go create a window and fulgurate the sac and ligate the proximal sac, indirect sac. And then we continue with the paratalization of the cord structures till we need at least 5 to 6 centimeter below the deep ring and 2 to 3 centimeter below the pubic bones. And on the lateral aspect, we go up to the anterior superior iliac spine. So this is the triangle of doom. And after that, we put the mesh in the covering all the potential sites for inguinal and groin hernia. And we can tag the mesh or the fix by the sutures. Suture fixation is recommended nowadays because tackers produces sometimes nerve entrapment and chronic groin pain. So it's better to learn the suturing, endoscopic suturing, and fix the mesh by suturing. And after that, we go into the suture the peritoneum incision that we have created. That we need to extra peritonealize the mesh completely. This is the reason that there are less chances of recurrence in laparoscopic hernia repair for groin, because when we cover all the uh, potential sites for groin hernia by a large mesh and fix it properly, so there's no reason why should hernia recur. So understanding the anatomy of groin plays a pivotal role in laparoscopic hernia repair. Laparoscopic repair, that is a deep or posterior repair, we call it, deals with the point of origin of hernia. We deal with a deep ring there versus point of presentation when we deal in the open inguinal hernia repair. So this produces important results, that is the minimal recurrence. Firstly, the inlay posterior placement of mesh gives a mechanical advantage. There's a Pascal's law of hydrostatic pressure that indicates that posterior mesh repair is the better repair for all kinds of hernia. Secondly, bigger mesh covering the all potential sites of myopectoral orifice. So I recommend to all be updated. If you are not updated, you are outdated. It's only the matter of attitude. So change your attitude towards the laparoscopic hernia repair. That's all from my side. Thanks.
Very nice presentation, Dr. Chawla. Uh, you have emphasized a lot upon the anatomy, and I must say, surgery is nothing but opening up the various planes which the God has created for the surgeons. And you have very well delineated all the anatomical structures which are required for the inguinal hernia surgeries. I would just like to emphasize a few points which we have already told, that the triangle of doom. So the triangle of doom, the content is the external like vessel, and it is called the triangle of doom because if you happen to dissect in that triangle, then you are going to land up in doom. There will be a very torrential bleeding which will not be controlled by any manners. Another thing that you have already emphasized is the triangle of pain. If by chance you dissect in the triangle of pain and your mesh comes in contact with those nerves, then the patient is going to have a chronic pain, and that will be very difficult to deal with. So these two triangles, they have to be taken care of, especially during the anatomy of the inguinal canal. Then another point would be a surgeon must be well versed in both open hernia repairs as well as the laparoscopic hernia repairs. An untold dictum is that if the patient is having a recurrence after open hernia, it's better to go with a laparoscopic procedure. And if there is a recurrence after laparoscopic surgery, then a surgeon would be inclined to do an open surgery. Although a redo by a laparoscopic surgery can be done, but that's difficult procedure. So a surgeon must be well versed with the anatomy, both open versus the endoscopic method. And let me be bold enough to say that the time is coming for the laparoscopic surgeries of the hernia, and it is already established fact that it is a gold standard treatment for the hernia repairs.
Thank you, Dr. Shireesh, Dr. Chawla, sir. It was a nice presentation. I would like to add some points in this presentation in respect of doing E-tap or TEP repair for the hernia. That was a good presentation around the TAPP. But when we do TEP or ETP for the inguinal hernia, that is well burst nowadays for inguinal hernia surgery and the incisional or ventral hernia surgery or AWR. In particular regards to inferior epigastric vessels, there is single artery, that is the inferior epigastric artery, and accompanying that there is a two inferior epigastric vein or two or three. You have to take care of that when you go from medial to lateral side or space of Bogros, creating the space. And during paratalization, we have to keep the inferior epigastric vessel up and the cord structures or structures below it, and we have to go for the lateral side up to the ASIS, lag span or lateral space. In that, we can injure the inferior epigastric vessels, artery or vein. In vein, we can simply cauterize it, or when the one vessels, when you go from the E-type space that is coming around the umbilicus, towards the umbilicus, that we have to clip it or cautery it with the harmonic or simple monopolar cautery. The second is, I would like to add for the corona mortis. When dealing with the direct hernia, especially when we reduce the direct sac, just below that there is the corona mortis or abnormal obturator artery. In around 40% cases, there is a vein communicating from the external iliac to the obturator vessels, and 2 to 3 there are, and 70 around 20% chances there are the artery, and there can be combined both artery and vein in around 60% of the cases. So we have to take care of that during the dissection of the direct hernial sac, and especially putting tacker over there over the Cooper's ligament, because the vessels run over that Cooper's ligament, we can injure and land up in the torrential bleeding. So we have to take care of that, especially in these cases during the mesh placement or during lateralization of the space. Thank you.
Thank you, Dr. Shireesh and Abadhesh, for wonderful comments and additions. You have mentioned crucial points. Dr. Shireesh has mentioned about the nerves and internal like vessels in the triangle, both the triangles of doom and triangles of pain. That is why I already told that we need to dissect in the space of Bogros, that is between the peritoneum and the fascia. Remember, this is the pre-peritoneal repairs, whether TEP or TEPP or ETAP. It's not a prefacial. So we need to be between the peritoneum and the fascia only, not between the two layers of fascia, because there are the vessels. And we need to preserve the fascia over the internal iliac vessels and the nerves laterally in the triangle of pain. That is and rightly mentioned that we need to be very well versed with the open inguinal hernia repair, because open repair still has a role in today's era also. There are so many patients which may not be subjected to laparoscopic even in the primary hernia, and definitely after the recurrence of laparoscopic hernia repair, we need to guidelines say that open repair is the best repair. Open should be recommended. Though we can do this laparoscopic hernia repair also after the recurrence of laparoscopic hernia repair, but that needs is very vast experience and very well knowledge of anatomies and modern all energy sources and all these things. And corona motis, Dr. Abadhesh has mentioned beautifully that we need to take care while dissecting and while putting the tags, while putting to fix the mesh. So,
since we have time, from the point of view, you want to say
I'll
something?
just
Yeah,
take a
please.
question. So just for the audience, so I remember back in I attended a conference at ASI Jodhpur. So they presented a paper where, like you'd mentioned also pertainingly, that you're not using tacker anymore, you're suturing to fix the mesh. So how far does your practice go on that? Because I remember back in my days, we were transitioning from suturing to tackers. And you made a comment that you're now using sutures than tackers.
I will add a counter question to that. Three things. One, if you are doing a pre-peritoneal repair, one is whether you need to fix the mesh or you just place it and close the peritoneum. Second,
Yes.
what Prekshit said, that if you need to fix, suture is better or tacker is better. And if it is tacker, how many tackers?
So my next
Because
question
these are the questions which we ask the students in the exam also.
right, and they presented a very beautiful paper at Asiraj, I remember. So they were not fixing the mesh. They did about 100 cases where they were not fixing the mesh at all.
actually, what guidelines say is there is no need to fix the mesh in totally extraperitoneal mesh, whether it's a TP or ETAP. Guidelines say until and unless it's a M3 type of hernia. That is a big hernia on the medial aspect. That is a direct hernia, which is larger than the 3 to 4 centimeter defect size. They say then there is a need to fix the mesh. Otherwise, there may be a ballooning of the mesh which goes into the defect if you don't close the defect. That is for the TEP and ETAP. TEPP, still the recommendation is you need to fix the mesh because there is always a bigger space created in the TEPP, and there is always a loose peritoneum there, and because of opening of the peritoneum and all these things. I personally feel mesh should be fixed to prevent the recurrence. Our goal is to have a zero recurrence. Although we are still not able to reach to that level, that zero recurrence. And next question is taker or suture. Both are recommended and both are guidelines say both can be used depending on your experience and your expertise and resources and what you feel. But there are some papers that say takers may cause pain. It's not that I always use suture fixation for the mesh. I also use the takers for fixing the mesh. Uh, when you are in hurry, when patient is compromised, you want to do it early because suturing takes a time. Mesh fixation with the suture takes at least 5 to 7 minutes, at least. And when you start learning suturing the mesh, peritoneum suturing is a different aspect, altogether different aspect, and suturing the mesh is a different aspect. Peritoneum suturing takes you only 2 3 minutes, hardly takes an. If you have gained enough experience, suturing of the mesh or the closure of the defect, direct defect, still takes time. Takes at least 10 to 15 minutes. Initially, it may take you maybe 30 to 40 minutes also. Even after the expertise, you can take 5 10 minutes extra. So at times you feel it's a bilateral hernia, you have a list going on, there is a pending list, so you just fix the tags. There's no contraindication to the tags, but suturing is better because it avoids the nerves entrapment and postoperative chronic groin pain.
I have a question to Shireesh sir also. So, what is your preference?
And number of tags. They say 2 tags on the Cooper's ligament is enough for the suturing, for the fixation of the mesh. But I always use 4 tags. It's my personal listing. Again, the reason is I don't want my mesh to be rolled up. I don't want my patient to have a recurrence. I fix 1 tag at the Cooper's ligament, 1 on the lateral aspect just above the maybe 1 to 2 centimeter above the iliopubic tract, and 1 on the medial upper and 1 on the lateral upper corners.
Exactly how so I worked with Professor Misha as well. So he do exactly the same. He tag at 4 of these places.
I've been using this tagging since I think 2003 or 2004, still continuing with the same thing. And one question Dr. Abadhesh has raised: the TEP and this ETAP or TAPP hardly makes any difference for the patient. It is for the surgeons. Whatever you have learned, whatever you are comfortable with. I especially mentioned all the things about TAPP because it's an anatomy class. So I wanted to be, if you, for the new surgeons, there may be some residents also or novice surgeons also. So whenever you do appendix, whenever you do lap chole, just peep into the inguinal region. So you need to orient yourself again and again, again and again.
Rightly said, sir. Truly, for the first time when you are doing for TEP or ETP, you must know about the TAPP. When you land up with the ETAP or it is not completable, then you may convert to TAPP. So TAPP anatomy must be known for new surgeons, I think.
And there is TAPP is a one procedure which
all must know about.
Which can bails you out with difficult cases like strangulated cases, obstructed cases, and today's era, robots are coming. So TAPP is the better procedure for the robots also.
We have Dr. Aakanksha here from radiology. We can make use of her presence. So, inguinal hernia is a clinical diagnosis, but do you think there is a role of imaging, ultrasound, or CT in the diagnosis of a pre-hernia, sports hernia, evaluation of groin pain? And second, can radiology help us to detect these aberrant vessels?
Yes, sir, most definitely. So we do get routinely in the hospital referrals for evaluation of patients prior to surgery, even for inguinal hernias, where we measure the defects. Like sir said, I think when they are medial hernias larger than 3 to 4 centimeters, your surgical plan might change. You might want to, like you said, you have to fix it. So we try to give you the exact location, the exact size, what is herniating.
This is on ultrasound.
Yes, sir. Everything is on ultrasound because ultrasound is a dynamic procedure. When the patient is lying down, we ask them to raise the intra-abdominal pressure either by Valsalva or just raising their legs up, and that makes the bulge more prominent. We can see what is herniating. Like sometimes at rest, there is nothing that comes out into the sac, but when the patient's abdominal pressure is raised, either the momentum passes through, sometimes bowel passes through, so we know what is going in and out, and we can get like a proper assessment of the contents of the sac. About the vascularity, this communicating branch, which is of a danger, we can pick that up using Doppler. I have never reported it, but now when I was listening, I was like, okay, next hernia patient, I'm going to try and see this vessel if we can pick it up and tell you prior to surgery.
We should try to see whether the radiologist can detect it.
Most definitely.
That will make the life easy.
At least you know that there is something.
Because now with the probes, we can see everything.
Yes.
Like we have chronic groin hernia patients in whom we find out the nerves which have scarred post-surgery, like in complications, and we try to hydrodissect them. So if we can see nerves, we can definitely see these vessels. So we are going to try do that now.
And I think there is one more indication for imaging. In today's era, these all government schemes and EPS, they are demanding imaging studies for the documentation of the hernia. Although we don't need for as far as the surgery is required, or that's the thing.
I'll have a question for Professor Shireesh. Sir, what is your choice of mesh in your daily practice? Like, definitely, if you take the financial constraints out, what is going to be the choice of mesh? I remember there's a variety of meshes that you get. A simple polypropylene,
If
probably.
money is not a constraint, then which mesh would
you prefer?
Sir, if the money is not constrained, then I would definitely prefer a 3D mesh, and I find it more comfortable, and it lies beautifully in the fossa. It covers all the defects beautifully, and it doesn't need any tacker to fix. It gets adhered to that fossa. So definitely a 3D mesh would be better. Although I don't find any much difference between the flat meshes and the 3D meshes practically. Post-operatively, when the patient comes in follow-ups, maybe after a week or maybe after 3 months, patient doesn't have any difference whether I put in a flat mesh or a 3D mesh. But for the surgeons, it becomes more comfortable to place a 3D mesh.
And from a polypropylene to a dual surface mesh, what would you prefer for inguinal hernia?
One can't even need a polypropylene mesh. You
Plain
don't need a
polypropylene.
dual mesh. That is required for the mesh if
Ventral
they're
hernia.
exposed to the intraperitoneal
All right.
contents. Then we need a dual mesh.
Next session. Thank you, Doctor.
Thank you, sir.
Shireesh, thank you, Abadhesh. Thank you.
Thank you.
So the next session we have Dr. Jaya Agarwal. She is an HPB transplant surgeon currently working at Amrita, Faridabad. She's delivered a lecture and published a paper on robotic right donor hepatectomy at IHPB at 2021, which also received a best paper. And she'll be talking about laparotomy and closure, being a gold medalist in anatomy herself.
And the discussers are Dr. Prekshit, who's a former consultant in general surgery, but now undergoing a course in surgical oncology, and Dr. Aakanksha from radiology. As the theme of the JSF is surgical, radiological, and endoscopic anatomy, I would once again like to put on record my appreciation for colleagues in anatomy and radiology for their valuable contribution to the proceedings.
Good morning, everyone. At the outset, I would like to thank Dr. Kapoor sir and the JSF team for inviting me here. And I bring greetings from Amrita Hospital, Faridabad. So till we're setting this up, I am really, firstly, when I was given this topic, I was surprised as to what should I speak on this topic. But as I went through literature, I realized that it may be more important than actually discussing about GI and HPB surgery, because this is something that determines the outcome of the patient. So till we are setting this up, so why are we discussing about laparotomy and closure? So when we see literature, wound-related complications have a very high incidence. The most important which is there that is causing significant morbidity to the patient include incisional hernias. And if we see evidence-wise, elective surgeries have incidence of as high as about 15 to 20%, whereas emergency surgeries have incidence of incisional hernias, which are even more, ranging to as much as 45 to 50%. Besides incisional hernias, the incidence of facial dehiscence, which leads to high morbidity as well as mortality rates of as high as 15%, are reported in literature. So to avoid such complications, the most important surgical modifiable factor is to ensure a proper closure technique. So for a very precise closure, what we need is that we need a precise incision, and we need to know the planes in which we enter the abdomen to ensure that we have a proper closure when we are finishing the surgery.
Let's continue in this format only. Yesterday also we faced the same problem. It's okay.
So as I mentioned, the single most modifiable factor is the closure technique. So in the first part of my presentation, I would be speaking about entry inside the abdomen. So the common indications for performing a laparotomy could be either in the elective setting, where surgeries are performed for oncological resections, such as any major GI pathology, or for if we're doing any surgery for inflammatory bowel disease, if we're doing any vascular procedures in the abdomen, such as an open aortic aneurysm repair, or if you're performing any surgery for benign diseases such as ventral hernia repairs or surgical management of pancreatitis. Besides elective indications for a laparotomy, there could be emergency indications for a laparotomy as well, which include trauma, which can be blunt or penetrating. And the surgeries are performed for peritonitis or obstruction, or if there's a massive uncontrolled hemorrhage, we need, and which is unresponsive to endoscopic or interventional procedures, would require an emergency laparotomy. So if to know how to open the abdomen, the first and foremost thing is to know about the anatomy of the anterior abdominal wall. Anterior abdominal wall anatomy, anterior abdominal wall reconstruction is coming up in a big way, and there have been societies set up that teach students about anterior wall reconstruction and anatomy. So the key layers that we see in the midline is first and foremost the skin, followed by the subcutaneous fascia, which is further divided into the campus and the scarpa's fascia. In the midline, we have the fusion of the fascias that form the linea alba, and that is the target when we are doing a midline laparotomy. Followed below the linea alba comes the preperitoneal fat in the upper part, the falciform ligament, and below that lies the peritoneum, which ultimately gives us the entry inside the abdomen. So this anatomy is in the midline. Laterally, we have the rectus abdominis muscle that is wrapped with the anterior posterior sheath. The anterior posterior sheath fuse in the midline to form the linea alba. And even more laterally lie the three main muscles of the anterior abdominal wall. The innermost muscle is the transverse muscle called the transversus muscle. Above that is the internal oblique, and most superficial muscle is the external oblique. So when we are doing a laparotomy, there are a variety of incisions that are available to us, out of which the workhorse incision for any surgical procedure in the abdomen is generally a midline incision. And any surgeon who is going to explore the abdomen should be well versed of how to perform a proper midline incision. So whenever we are doing the open surgery, we should not hesitate in giving a wide incision, because the most important thing that will determine the outcome, the results of our surgery, is a proper exposure. So giving an incision that is 1 centimeter less or more is not going to give any cosmetic benefit, but it is going to significantly hamper the exposure that we have when we are performing a laparotomy. So the midline incision is the workhorse, and it is one of the most favored incisions by a surgeon because it provides a good access to all the quadrants of the abdomen. It is pretty rapid to perform, and that is useful in cases of emergency like obstruction, perforation, or even a trauma. It is relatively bloodless because our target is the linea alba, which is in the midline, and it's an avascular plane. And we can extend it in either the above direction or the infraumbilical direction, depending upon where the pathology lies. Suppose we feel initially that the pathology is in the lower abdomen, but when we open the abdomen, we feel that either the lesser sac, the colon, or the stomach may be involved, and we want to extend it supraumbilically. It is very easy to do so with the midline incision, and may not be that easy if we consider the other incisions in the abdomen. And also with the midline incision, there is minimal damage to the nerves in the abdomen, as well as we don't have to cut any muscles. However, midline incisions have one of the highest rates of incisional hernias because it is a weaker part of the abdomen. So the other incision options that we have is a subcostal incision, which is also known as a Cocker's incision. It is an oblique incision that is given 2 to 3 centimeter below the right costal margin. So this is the classic incision that was performed previously for surgeries like open cholecystectomy, because it gives an excellent exposure to the right upper quadrant, the liver, the entire biliary tree. So even if we have to perform and if we have to convert from a laparoscopic surgery to an open cholecystectomy, the subcostal or the Cocker's incision is the preferred incision. So followed, if we do a bilateral subcoccus incision, that's called the rooftop or the chevron incision. So this incision is called the chevron incision. It's a very big incision, but it gives an excellent exposure, especially in cases where we need to do major HPB surgeries and where vascular resections are needed, and also in cases of liver transplantation, as it provides a wide exposure to the abdomen. If we give it a vertical upward extension that becomes a Mercedes-Benz incision, because it is similar to the symbol of the Mercedes-Benz car. The previously used paramedian incisions are pretty much historical now. They are lateral to the midline and it opens the rectus sheath. So it has fell out of favor mainly because of the difficulty, the time, and it has no proven benefit over the midline incision. Another abdominal incision that can be commonly used is a transverse incision. This follows the Langer's line and it is preferred in the pediatric age group. It can provide a good and a focused exposure and can also be extended, though the vertical extensions are pretty difficult with it. It is associated with lesser pain and a better cosmesis, and also it's associated with lower hernia rates. So the pros with other incisions other than the midline is that it has a lower hernia rate and lesser pain as compared to midline incisions. However, these incisions are slower to perform. They are usually muscle cutting and can lead to more bleeding and can give a limited exposure, especially if we want to extend the incision to access different area in the abdomen. It is difficult to do so with these incisions. So how do we decide which is the best incision and what will give us the best results when we are doing a laparotomy on a patient? So first and foremost, we need to find out what is our primary target organ and how much exposure would be required when we're doing the surgery. So exposure is the first thing that determines which incision we would be making when we're doing the laparotomy. Exposure with, again, guide our extensibility. Suppose we are dealing with any bowel pathology and we feel that we need to examine the upper quadrant for some reason. So we need an incision that can be easily extended. Like if we're doing a subcostal incision and we realize we need to evaluate the small bowel, it can be done, but it is difficult. So midline incision wins here when it comes to extensibility. Thirdly, we need to be fast in the incision, especially in cases of emergencies when we are operating on a bleeding trauma patient. Again, midline scores over other incisions when it comes to speed. If the patient has undergone any previous surgery and there's already a scar on the abdomen, we can reuse it. And if our primary target organ lies within that reach, and if a stoma is planned, we can first mark the stoma and then probably plan the incision around it, though this may not be that important. The most important thing that when we need to take care of when we are making the incision is that what is our primary organ and how much exposure we will get from that incision. So steps to summarize when our entry inside the abdomen is, the first step is to cut the skin with the 11 number blade and give it a single clean cut. There should be no hesitation marks, because ultimately whatever major surgery you have done, the incision is something that the patient sees and carries for the rest of his life. So we can make it as good as possible. Step 2 is we go through the subcutaneous fascia. We use diathermy cautery here to dissect till we reach the fascia. Step 3 is to cut the fascia, clear the fat of the fascia and cut it with a cautery, and generally try and avoid old scars if possible, because they are poor healing sources. Finally, we enter the peritoneum. Peritoneum entry is the most important thing, and all the injuries of entering inside the abdomen happen when we are opening the peritoneum. So we need to be very careful that we are not taking any underlying small bowel, stomach, or colon when we are entering the peritoneum. So the ideal technique would be to lift it up with 2 artery forceps, feel for it that there's no other structure in it before you cut it with a scissors. Never use cautery when you're entering the peritoneum, because by chance, if a bowel injury is there, it's not a thermal injury and it's a clean cut injury, can be repaired, but try and avoid such mishaps as much as possible. So now coming to the second part of the presentation, it would be on how to close the laparotomy wound. So there's a popular phrase from the Surgical Principles by Theodore Billroth. He said the operation is not over until the skin is closed, and it should be closed well. So the main principle and goal behind a good abdominal closure is to achieve a durable facial apposition to allow for physiological healing without strangulation of the tissue. So the main principles of closure is to achieve a tension-free closure, and it should incorporate the strongest tissue that is available in the incision, which is generally the fascia. An appropriate durable suture with an appropriate needle size is a must to achieve a good closure. We need to minimize the dead space as much as possible to avoid wound infections and ensure adequate hemostasis. So we are all aware of the 3 phases of the wound healing, in which the first phase is the inflammatory phase, followed by the proliferative phase, and finally is the remodeling phase. So the critical phase in wound healing generally has a time frame of about 6 to 8 weeks, and whatever suture we are using should be durable enough to last that long. So multiple studies, multiple literature, randomized control trials, and RCTs are available that study the different type of sutures that can be used for the abdominal wound. So this is a table from a recent RCT that showed they compared 4 sutures, which is mainly polydioxone, the PDS, Vicryl or the polyglactin, proline, and silk sutures for facial closure in the abdominal wall. So out of this table, we can see that 2 sutures, that is PDS and proline, are monofilament sutures, whereas Vicryl and silk are multifilament. And the other thing that they studied was whether it's an absorbable or non-absorbable suture. So from the RCT, they concluded that an ideal preferred suture for facial closure would be an absorbable monofilament suture, but that has a delayed absorption so that we are able to overcome the critical phase of wound healing. Vicryl absorbs too fast and it is found to be a very poor suture for abdominal closure. Silk is a braided suture and it carries a very high risk of SSI and should be avoided for abdominal facial closure. Proline is also a good suture, though it is a non-absorbable suture, can be used in cases where we are applying a mesh, but for routine abdominal closure, it carries a higher risk of sinus formation. So as I discussed in the previous slide, so an ideal suture should be a slowly absorbable suture that could withstand the critical healing phase of 6 to 8 weeks. For example, PDS retains its 50% strength at 6 weeks and it is ideal for abdominal closure. A monofilament is ideal because it carries a less friction and drag when we are taking a bite, and it is not an nidus for bacterial infection. However, it is a stiffer suture and it has less knot security, so we need to have multiple throws when we are using a PDS suture. Rapidly absorbable is not a good idea because it is not able to overcome the critical phase, and multifilament is a nidus for bacterial infection, so should be avoided to prevent SSIs.
Yeah, you have 5.
Yes. So this is another meta-analysis that came up as early as 1998, and overall from multiple consensus guidelines, including the ESS guidelines, number 1, loop PDS is a slowly absorbable monofilament suture and is the most commonly advisable suture for abdominal closure. Now coming to an ideal needle that should be used for abdominal closure is a taper needle, because we are suturing and not cutting. A taper needle or a round body needle will minimize the hole size, which is ideal for facial closure. If we are using a cutting needle, it will give us a larger hole size and that would weaken the closure. Also, large bites are present with larger needle sizes, so an ideal needle size should be used when we are doing a facial closure. Now, there are multiple debates on how to close the abdomen, whether it should be a mass closure, whether it should be a layered closure, whether it should be a continuous or an interrupted closure. So from various updated guidelines, the consensus is a continuous mass closure. Mass closure would be to incorporate all the layers of the rectus sheath in one bite and not take the separate layers, like not take the sheath separately, muscle separately. That is not recommended. A continuous suture is better than an interrupted suture, though if the facial traction is there, then in such cases interrupted is preferred. But the cons with interrupted is that each throw would be we'll have to have multiple throws in each bite, and that would weaken the sheath closure. So this stitch trial came up, which showed that this is another area of debate, whether the bite should be a large bite or a small bite. So traditionally, the large bite concept was there, where they say that each bite on the facial closure should be 1 centimeter apart from the incised end and should be 1 centimeter gap should be there between the 2 throws. But the stitch trial showed that smaller bites, which is 5 millimeter away from the incision, and 5 millimeter apart sutures have a lesser rate of incisional hernia at 1 year. Small bites at 13%, whereas large bites at 21%, though they did not find any difference in wound infection or burst abdomen rates. Another rule that we need to follow in facial closures is the Jenkins rule, which says that the suture length to the wound length ratio should be 4:1. So as they popularly say, if you're a miser, you'll be miserable. So do not try and save on the suture. It is not going to help the patient in the long run. So ideally, keep the suture length 4 times as the wound length. Prophylactic mesh can be used.
Take few more minutes.
So prophylactic mesh can be used in high risk cases only. Its main principle is a goal to reinforce and not replace. So when patients are very obese, their history of previous hernia, they are chronic COPD smokers, and there are guidelines for open aortic aneurysm repair or closure of a previous stoma site, prophylactic mesh can be considered, though it is not a routine practice. Finally, coming to the closure of skin and subcutaneous tissue. So subcutaneous tissue should only be closed if you feel that the fat layer is too deep, that is more than 2 centimeter deep. Otherwise, we can avoid closure of the subcutaneous tissue. The main aim is to reduce the dead space to prevent the seroma formation. And subcutaneous tissue is generally closed with absorbable vicryl sutures. Avoid strangulating too much on the fat because that can cause necrosis and infection. There are various ways in which you can close the skin. It can be closed using staples, which is the fastest technique, though it gives a poor scar. Subcuticular suture, though time consuming, gives the best scars. And zips and glues can be used, though they are costly. In cases where we are unable to close the abdomen or we need to re-explore the patient, or in emergency settings where the closure would be very tight, temporary abdominal closure methods can be used. The gold standard is to use a VAC therapy. Also, Bogota bags can be used where a simple plastic can be applied to the skin edges. However, it can lead to loss of domain as well as lot of fluid losses. There are Velcro patches available, but they are complex and costly to use. So I'd skip this complications, wherein the two most common and dreaded complications, one is the facial dehiscence, which generally occurs on day 5 to 10, and is the pathognomic sign is the salmon colored serosanguinous fluid that will be coming out from the wound. It carries a very high mortality, so we should be on a lookout for it. If such a thing happens, the patient should be taken back to the OT, and proper care should be taken to reclose the abdomen and apply alternate methods such as VAC, so as to prevent the patient from having a bad outcome. Incisional hernias are generally long-term complications, generally happen either due to poor surgical technique or patient factors, or if the patient has developed a post-operative infection. If the patient is asymptomatic, a waitful watching can be done. However, if the symptoms are present, an open or a laparoscopic repair with a mesh should be performed. So I'd like to conclude by saying that a precise incision is the foundation of a secure closure. Adequate incision for a wide exposure prevents complications. A mass continuous closure is the preferred technique. Length of the suture should be adequate. Never try and save on the suture length. You will be miserable later on in the post-op. A tension-free closure is very important to avoid complications. And the incision, you should be as fresh in the closure as the incision. There are a lot of teams in India as well in outside countries like Korea, where they get in a new team just for an abdominal closure. Or prefer, if you're very tired after a long surgery, it's better to take a break, come back fresh and do the closure, because it is as important as doing the complex surgery that you have done so far. Thank you.
So I think an excellent presentation where you've covered mostly all of it, and thank you so much for all the insight that you've given us. I'd just like to mention 3-4 points. First of all, there's a new, not very new, but then we using Makuchi quite oftenly now these days. So Makuchi and a reverse Makuchi is quite convenient for us for the upper abdominal viscera, especially HPB, and also for renal resections. So that's one thing. The second thing is also, when you're doing a re-laparotomy, we'd like to identify the virgin area. For the audience, always go and we start from the virgin area, then either picking a different incision or probably, I would definitely prefer a midline incision. But if I'm getting an access from the midline, and if I can see a virgin area, I'd like to start from there because nothing is more comfortable than a midline incision. Third, I think we, as the newer generation of surgeons, we're all moving towards monofilament sutures. I think braided is out in the market. Like you go for skin, I'd prefer a monocryl or a ethelon. You go for a gut, I'd prefer a PDS over a vicryl or sil. And if we talk about a vascular anastomosis, I think nothing breaks Prolene on that. So we're moving, the world is moving towards monofilament sutures. Lastly, I think the closure method is now standard. Nothing has changed in it. So we use a slowly absorbable monofilament suture with small facial bites in a continuous single layer with a suture length to a wound length of 4:1, which is now a standard practice everywhere. Lastly, what I want to cover a little bit is the emergency closure in a setting of an emergency laparotomy where I think spillage risk is too much. We've already had a GI perforation, the fascia is contaminated. There are a variety of methods that people have practiced overall. And the reason I'm bringing this up is also because I've done a thesis on this. And you do a delayed primary closure. We tried a lot of other methods, but I think nothing came out better than a delayed primary closure. There were a set of uh, practices we were doing in our department, although not anecdotal, but we were using a drain. We've left the whole wound open. We've tried to close it later on. But I think delayed primary closure turned out to be the best, where we would, like just suture out the umbilicus or probably half of the suture, half of the incision length, and we leave the rest to drain. And then we'd probably go back after 3-4 days or probably 7 days and do a suturing. And worthwhile that we did the study on a patient of roughly 357 number, and we've still not had any incisional hernias in any one of them. So there was a good number that we practiced. I think
So when you say
that's it.
delayed primary closure, you mean delayed closure of the faciophonoretic layer
Exactly.
also,
No,
not only the skin.
we do the facial closure, sir, in the same standard method. If we're getting the sheath, we do the sheath closure with a monofilament 4:1 small bites, but we leave the subcutaneous plane and the skin open.
Yes.
And just 2 or 3 tagging sutures, that's it, so that the fluid gets drained, and then we go back in and close the.
Because
It's a very outdoor patient procedure to close the skin and subcutaneous tissue.
Because in some situations where there's a lot of edema of the bowel, there's a lot of dilatation of bowel loops, even the facial closure may not be possible. So in that case, it is better that you just close the skin, accept a defect, but not a dehiscence, not a burst. And then once the abdomen settles, then you can go in and close. Yeah, you have a presentation?
Wonderful presentation, ma'am. Thank you for detailing the.
Yes, please.
So a lot of focus is on the closure techniques. I think there are one thing that we miss is knots. So the first knot and the last knot needs to be knot which does not get open on traction. So the first knot is like, I think 1 or 2 studies have shown that the first knot, if we take a fish knot and the last knot as the Aberdeen knot. So that type of closure holds strength even when the traction is placed on the abdominal, much more pressure in the abdominal area, especially in emergency cases or in even our routine laparotomy closure. So they have shown that these kind of knots held better than any other, like a simple knot.
And actually for the first knot, if you're using a loop suture, you avoid a knot in the beginning.
Also, if we put an artery and plate, so those loops get loosened up. So, but if you take a fish knot over there, when you put an artery over there, instead of loosening it up, it tightens more. So it holds the sheaths together, even if we are taking the first as a fish knot.
Also, the last thing, like if we have a long closure, like we do a lot of exiphy to the pubic symphysis incisions. So I'd rather than taking a single suture from down to bottom up to up, I take 2 sutures and knot them in the midline, which like small sutures loose, but then we knot them in the midline, which gives much better results. Then even the patient is more comfortable with that, I feel. Thank you.
You should always bury the knot also, otherwise that chronic pain keeps on persisting in the long term.
Yeah.
So being a radiologist, I think my images would speak more than my words. So like ma'am mentioned, the importance of closure lies in avoidance of wound complications. So usually the first radiological investigation that is done is an ultrasound, but ultrasound becomes a challenge when the wound is open, like you said in emergency laparotomy cases, or there is like active bleeding or active drainage happening from the wound site, and when there are a lot of bandages in the immediate post-op period. But even then, we can see cases like seroma, accumulation of seroma in the subcutaneous soft tissues. There can also be collections in the subcutaneous soft tissues. These things can be identified on ultrasound by the difference of their appearances. Like seromas tend to be very clear, while collections have a more heterogeneous appearance and a little more vascularity around them. So usually when we see such things, if there is an abscess, of course, the surgeons might want to intervene, but a seroma is usually followed up for resolution. Then these are, like ma'am mentioned, incisional hernias can occur. Incisional hernias can just have omentum herniating through them, and we can tell you the gap, the size of the hernia that is there. And sometimes even the bowel or an intraperitoneal fluid can herniate out through the incisional hernias if the intra-abdominal pressure is very high. In more complex cases where there is wound dehiscence, burst abdomen, we are not usually able to perform an ultrasound because of the open nature of the wound. In such cases, you might want to go for a CD. This is a volumetric 3D recon which shows the dehiscent wound. And contrast CT is used to evaluate the viability of the underlying bowel. For each patient, we need to tailor the CT protocol depending upon the clinical question and the clinical concern. And in the post-op periods, we can identify drain placements inside the wound, inside the abdomen better on CTs because of presence of air, which limits ultrasound. And another thing is we can find out retained foreign bodies or surgical materials which gradually envelop, get encased in a capsule and form a collection, also better delineated and confirmed on a CT. And then again, if your seroma does not get resolved on its own, we can always aspirate it. So yeah, these are the imaging perspectives that we can.
Thank you. Since we have time, Jaya, I have a few questions on behalf of the students. So when you are closing, do you take the peritoneum? Does it not matter, or you intentionally avoid the peritoneum?
Go ahead, sir. So we do not make sure that it is there in each bite, sir. What is the most important thing that should come in the closure is the anterior sheath. We cannot miss that at any point. The remaining things, if it is coming well and good, but if it has separated, we will not make a conscious effort to grab it in each bite because that would lead to more injuries than any good to the patient.
Second is mass closure. Now, if you have made a subcostal incision, would you do a mass closure, or would you close posterior muscles and sheath in one layer and the anterior muscles and sheath in another layer?
So initial school of thought was, yes, we will do a 2-layer closure, sir, but now the evidence is coming for a mass closure itself.
But again, a word of caution that if you are using mass closure for a subcostal incision, because there are multiple layers of muscles and aponeurosis, you must make sure that all layers are included and no layer is retracting and not getting into your bite. If you have to make a long midline incision, upper going below umbilicus or lower going above umbilicus, what do you do? Through the umbilicus or skirt the umbilicus?
Skirt the umbilicus, sir. Because the closure would be better if we go skirt the umbilicus. If we go through the umbilicus, that will be a weak area and it would be difficult to heal.
All laparoscopic procedures are now being done through the umbilicus.
Sir, but the rates of incisional hernias are not reported, are still there, sir.
Any view? Glue you mentioned. Now, okay. आप कुछ कहना चाह रहे हैं? नहीं, because you people do more laparoscopic surgery than I have done. So, yes, please.
I generally avoid umbilicus for the first camera port. Mainly the camera port are made in the umbilicus or the periumbilical region. I usually take my camera port just above the umbilical or just below the umbilical, depending on the which surgery we are using. In hernia, TAPP, again, first camera port is around 3 to 4 centimeter above the umbilical. That gives a better triangulation, and the lateral ports are at the level of umbilical on the pararectal pararectal line.
Again, I would also like to corroborate what Dr. Chawla sir had said. I usually avoid umbilical ports. Umbilicus being a scar doesn't have a good healing, or prone to develop hernias. If I keep my first port just above the umbilicus or below it, it gives a better healing. And definitely any port which is more than 10 millimeter, ideally they should be closed. They should not be left open, so there are lesser chances of hernias.
What about sills?
Stills, we have been using stills in, I think, 2009, 10, 11. I think all over the world, stills is being not promoted or not being practiced much. There are few surgeons who are doing as a routine, especially in bariatric surgery. What I prefer is there is hardly any difference between 3 ports or 4 ports or 5 ports as far as the safety of the surgery is concerned. You have been master in the laparoscopic cholecystectomy. I say laparoscopic cholecystectomy is the one surgery in which surgeon should never try any experiments because complications are dreaded.
Prekshit, you wanted to say something?
Sir, about the umbilical incision, I would always want to take something that is either above or below because I want to be prepared for a midline incision. Anytime, if I need to open up, I think the easiest access is you take that incision up or you take that incision down.
Yeah, so even for conventional laparoscopic surgery, when we say that the camera port is at the umbilicus, it is not actually through the umbilicus. It is where the vertical umbilical scar meets the horizontal linea. And that is where you make the incision because that is where the amount of preperitoneal fat is very little. So if you are doing an open technique of first port insertion, that is where you make the nick with your knife first and then put in an artery forceps, make sure that it is moving freely in all directions, and then enlarge it. Now, since we have time, Akanksha, the most important thing that we are worried about when making the incision is, especially if the patient has previous scars and surgeries, is adhesions. Why is it that till today there is no radiological investigation which can tell us about adhesions? Are there any advances on that?
So you mean intra-abdominal, like
Yes.
bowel adhesions?
Oh, adhesions to the
To the-
parietes,
So
basically.
to the parietes, so because I think we can tell you if the omental fat is stranded, if it is not very clean, that we can tell you on ultrasound and even on CT. But whether it is adhered or not is we can only tell you if there's something that comes in between those layers and moves it. So even if we do it like we cannot move it on by our own, like on our own. If we even if we ask the patient to raise abdominal pressure or anything, like I don't know if there's any maneuver to actually move the two layers. Like in fingers and joints, we can move and see if it is adhered or not. But I don't think if there's anything like that in the abdomen that we can do.
Because especially in our patients where tuberculosis is still common,
Yes.
we've had instances where while putting the first port by open incision, we have caused an injury to an adherent loop of bowel because of previous tuberculosis. The patient had no previous surgery. So I'm still waiting for an investigation which can tell a surgeon whether there are adhesions between bowel loops and parietes.
So if they are very tightly adhered, what we can actually do is if there is a high clinical suspicion, we can just keep the probe there and wait for the bowel to show the peristalsis and see if it goes through. Like that is
Even
something.
an adherent loop will have a
Have
peristalsis.
peristalsis, right?
You mentioned about glue for closure. So, is there any limit of the length of incision for which glue can or should not be used?
Generally, sir, it is used for minimally invasive techniques like laparoscopic or robotic techniques, but it is not preferred over big laparotomy incisions, especially if there's a high chance of surgical site infection because that tends the infection accumulates below and doesn't come out. So it's not a very good modality, though for smaller incisions, maybe less than a centimeter size, it can be used, but for longer laparotomies, I don't think it is a advisable thing to use.
And coming back to the emergency laparotomy, where closure may be difficult, suppose the surgeon is finding that, yes, if you pull too much on the parietal wall, you can approximate, but you know that there will be tension. So what do you advise in such cases? Should we close or should we as we discussed earlier, just approximate the skin, let the edema subside, accept a kind of temporary incisional hernia, and then go in later and do a proper repair in ideal conditions, or something like that, you close part of the incision, above part below, leave the middle part, even the facial sheath, I'm saying, open. So what are the options which are available? Because we frequently face these situations, especially in emergency, especially in patients with intestinal obstruction, perforation peritonitis, pancreatic necrosectomy, and all, where there's a lot of ileus. So what do you suggest?
Sir, if the patient is hemodynamically stable and if we feel that the tension is not that much, then we can probably give relaxing incisions on the sheath laterally and approximate it. But if we feel that there is any hemodynamic instability or the tension is too much, bowel edema is significant, a proper skin closure and avoiding a facial closure at that point of time, accepting that an incisional hernia is there, may be a better idea. In that way, we will be able to avoid a compartment also, which will help in the post-operative management of the patient as well.
And just one more minute, we didn't touch on the so-called tension sutures, going through the skin and all the layers and then tightening them over pieces of rubber.
Tension sutures, sir, are not that frequently used.
I would even be more emphatic and say that they should not be used,
Yes,
because they tend to cut through and cause more problems.
problems.
So just for the benefit of students. Yeah. Thank you. Thank you, Jaya.
And one point can I make here?
Yes, yes, please.
See, regarding the skin incision in the midline, the curvature around the umbilicus also can be planned. Suppose if you are planning an ileostomy, that can be
Yes.
made on the left
Other
side,
side.
or in the case of colostomy, it can be on the right side.
Very important, very important. So you should anticipate whether you are going to have, especially in emergency, in elective, you know, but in emergency, you should anticipate whether you are going to need a stoma, and then accordingly make the curve on the opposite side. Very, very important point.
So I would also
Yes.
like to comment, sir. One thing I would like to comment is, don't try to create spaces between the abdominal layers. Don't try to create a potential space. So cut sharp, and there is no potential space for the infection to develop. And I would like to ask, what's your take on this modified Smith-Jones method of closure, of mask closure, that is the far, near, far method?
Sir,
Is it better than the normal continuous closure?
the results haven't shown, sir, that the far, near, far makes any changes, though the concept of distributing the tension evenly over the rectus sheath is there. But the results have not shown any difference between hernia, because the far sutures, if it's a continuous suture, if one suture opens, the entire thing will definitely open. If there's a high chance of, if we feel that there's a high chance of sheath giving way, then best maybe to take in between interrupted sutures. When we are taking the continuous sutures, maybe in between interrupted sutures we can take, but otherwise the results have not shown that much of difference between a continuous suture and near far suture.
There's also technically so there's vascularity compromising. If you take a far, near, far, they're always constricting the vascularity between.
But there are few papers coming which are preferring this method, because there is an even distribution of the pressure and there is a better approximation of the facial layers. Maybe
Probably in
time.
time with time, sir. Sure. So we move on to the next. Thank you so much for that interesting discussion. So the next session for we have Professor Shireesh Gupta. Sir is a very senior general and laparoscopic surgeon. He's been my teacher, my mentor, and I call him an innovator for his new innovations that he does for his laparoscopic surgeries. The topic for the session would be surgical anatomy of incisional hernia repair. Over to you, Professor Shirish.
Yeah, good morning, everybody.
And also the discussers for the session are Professor Jitendra Chawla and Dr. Abadhesh Sharma.
Very overwhelming sessions going on a Sunday morning. It's really nice to see so many enthusiastic people joining us and hearing on a Sunday morning. So our topic was basically an incisional hernia. Incisional hernia, they're most commonly occurring after the midline laparotomies. That is the most common cause for the incisional hernia.
Sorry. एक बार stop share करके दोबारा share करो, ये फिर से problem आ रहा है. बोले अच्छा अभी आ. Okay, sorry.
So basically, to understand the repair of the incisional hernias, we must understand the anatomy of the abdominal wall that we have been talking about for the last 2 days We are emphasizing on the anatomy, why the anatomy has to be studied. For incisional hernia, we will be covering the anatomy of the abdominal wall. Again, that has already been told by Dr. Jaya. So I'll be just recapitulating what she has told us. The various layers of the abdominal wall. My favorite question to my UG students and the PG students is just name me all the layers of the anterior abdominal wall and I'll pass you. Just name it and it should be elaborate. All the layers should be told. And I'm sorry, it's very difficult for the residents to tell me the total layers of the abdominal wall. Anterior abdomen, it is basically a hexagonal area which is covered superiorly by the costal margins and the xiphoid process. Laterally, it is defined by the mid-axillary line. Inferiorly, it is limited by the iliac crest, pubic and the pubic symphysis. This anterior abdominal wall, it covers the inguinal region also, which has already been discussed in detail by Dr. Chawla. To study the abdomen, we usually divide it into 9 regions we are well versed with, and practically we divide it into 4 quadrants for the examination purpose. This is just to give you an overview of how complex an anterior abdominal wall is. So many muscles, structures, nerves, vessels are there, which we'll be talking about. Now, these are the layers of the anterior abdominal wall. If you study in detail, there are a lot of layers and each layer has their own importance, which has to be known. The first of all is the skin. Then there is a superficial fatty layer of the Camper's fascia. Then there is a fascia of Scarpa's, which is the membranous layer. And between these two layers lies the neurovascular supply, which is supplying the superficial part of the abdominal wall. That is the skin and the subcutaneous tissue. Then there is again a space of fat or the areolar tissue. Then there is a deep fascia. Deep fascia, it is formed by the investing layer of the muscle of the external oblique. So every muscle in the abdominal wall, they are not bare. They are covered by an investing fascia. So this deep fascia is formed by the investing layer of the external oblique muscle. Then we have the external oblique muscle. Then comes the inner investing fascia of the external oblique. This inner layer of the external oblique, it fuses with the outer investing layer of the internal oblique. Then there is an internal oblique muscle. Then the investing layer of the internal oblique muscle. Then there is a transverse abdominis muscle. Now between the internal oblique and the transverse abdominis muscle lies another important structure, that is the neurovascular bundle, which is supplying the anterior abdominal wall. After that, transverse abdominis muscle is the fascia transversalis. Now here is a little controversy. The old books and even the Gray's Anatomy till today, they say that the peritoneum, the pre-peritoneal part, it has got a parietal component as well as the visceral component of the pre-peritoneal tissue. Whereas we laparoscopic surgeons, especially the surgeons practicing hernia, we say that the fascia transversalis, the posterior layer of the fascia transversalis, is bilamellar. So there is a little controversy between what is being told in the Gray's Anatomy and what is being practiced by the laparoscopic surgeons. The superficial fascia, it lies between the dermis and the muscle. We all know there is a superficial fatty layer, that is Camper's fascia, and the deep membranous layer, which is the Scarpa's fascia. It contains fat, a variable amount depending upon the obesity of the person. There are a lot of cutaneous nerves, vessels, and the lymphatics. So these lies between these two layers of the superficial fascia. There are 5 muscles, 3 flat and the 2 vertical muscles, the external oblique, internal oblique, transverse abdominis, and the 2 vertical muscles, the rectus abdominis and the pyramidalis. These external internal oblique, they are called as the movers, whereas the transverse abdominis and the rectus abdominis, they are called the stabilizers of the abdominal wall. Talking about these muscles one by one, the origin of the external oblique muscle, basically this muscle runs downwards and medially and anteriorly. So the origin is above, upwards. So it originates from muscular slits from the outer surface of the lower 8 ribs. The fibers run downwards, forwards, medially, and they are inserted to the anterior 2/3 of the outer crest of the iliac crest. It forms an epineurosis which ends in the linea alba. whose fibers docusates with the fibers from the opposite side of the external oblique. The importance is there is an aponeurosis muscle junction, and this junction is not in a straight line. Basically, this junction starts from the tip of the almost from the tip of the ninth costal cartilage above and up to the line joining anterior superior iliac spine and the umbilicus. The lowest most part of this external oblique, it is interned to form the inguinal ligament. The anterior part of this inguinal ligament is hollow and which forms the inguinal canal. The lateral part is fused and forms the inguinal ligament. Then is the internal oblique muscle. The fibers of these, they are just perpendicular to the external oblique. So the origin lies below. So muscle goes from below upwards. The origin is from the lateral 2/3 of the inguinal ligament. Here we must remember that it is the lateral 2/3 of the inguinal ligament. That is why when we are opening up the hernia, inguinal hernias by open method, we will have some fleshy part of the muscles of the internal oblique. Whereas the transverse abdominis, it is tendinous only. Then the origin is from the anterior 2/3 of the intermediate area of the iliac crest and from the thoracolumbar fascia. The insertion, these fibers, they run upwards and they are inserted into the lower 3 or 4 ribs and their cartilages. And again, it forms a aponeurosis. This aponeurosis is formed almost at the lateral border of the rectus muscle. The aponeurosis of the internal oblique, it splits into the anterior and the posterior layer. The anterior layer fuses with the aponeurosis of the external oblique, whereas the posterior layer fuses with the aponeurosis of the transverse abdominis and it forms the rectus sheath, already discussed by Dr. Jaya. The aponeurosis muscle junction is roughly at the lateral border of the rectus muscle. Another important muscle is the transverse abdominis muscle. It is a transverse muscle. So the fibers are lying transversely. The origin is from the lateral third of the inguinal ligament. So that's why in the open inguinal hernia surgery, you will find only the aponeurotic part of the transverse abdominis, not the facial, not the muscular part of it. And then there is origin from the anterior 2/3 of the inner lip of the iliac crest, from the thoracolumbar fascia and the inner surface of the lower 6 cartilage. And these fibers, they are running transversely and forming the part of the inserting into the linea alba as an aponeurotic form. Again, a point to be noted here is the junction of the muscular part and the aponeurotic part. So it is much lateral in the middle part near the umbilicus, whereas above superiorly and inferiorly, it is more fleshy. So there is a lot of variation in the junction of the musculo-aponeurotic junction of this muscle. Rectus abdominis, it's a vertical muscle. So the origin is the pubic bone and the pubic crest and the anterior pubic ligament. The insertion is the fibers, they run upwards and they are inserted horizontally into the xiphoid process, 7th, 6th and 5th costal cartilages. There are multiple tendinous insertions. It doesn't have a tendon of its own at the ends or something. So there are many tendinous insertions in it, out of which 2 or 3 are fixed. They are always present. One is at the level of the umbilicus, the other is at the level of xiphoid process, and one between these two tendons. And there are 1 or 2 incomplete tendinous intersections below the umbilicus. This rectus sheath, this rectus abdominis muscle, it is covered by the rectus sheath anteriorly and posteriorly. Anterior is formed by the aponeurosis of external oblique and anterior lamina of the internal oblique, whereas the posterior sheath is formed by the transverse abdominis aponeurosis and the posterior lamina of the internal oblique. This posterior sheath is deficient below the arcuate line. Now the blood supply, basically divided into 3 parts known as the Hooger's zones. The zone 1 is supplied by the superior epigastric artery and the deep inferior epigastric artery, which has a variable level, it communicates with each other variably within the rectus abdominis muscle. Then there is a zone 2, which is supplied by the superficial epigastric, superficial circumflex and the superficial external pudendal arteries. This zone 2 lies in the lower part of the abdomen below the umbilicus. Then zone 3 is the lateral part of the abdominal wall, which is supplied by the lower 6 intercostal vessels, the subcostal artery, and the lumbar arteries. The nerve supply of the abdominal wall derives its nerve supply along with the dermatomes. So the various nerves supplying it is the ventral rami of the intercostals from T7 to T11, then the subcostal nerve, iliohypogastric, and the ilioinguinal nerve. So the supply is basically from T7 till L1. We supply the anti-abdominal wall. They run in the plane between the internal oblique and the transverse abdominis muscle, which is the most important point to be considered while operating on the anterior abdominal wall. Lymphatics, umbilicus is the watershed area. The lymphatics above the umbilicus, they drain into the axillary group of lymph nodes, and below the umbilicus, they drain into the inguinal group of lymph nodes. So these incisional hernias, they are mostly part of the ventral hernias. The other ventral hernias could be an umbilical hernia, paraumbilical hernia, epigastric hernia, which are the midline hernias. Then there could be lateral hernias like spigelial, lumbar hernias, and other rare forms of hernias. Now, why do you want to know the anatomy of the anterior abdominal wall in so much details? Because there are a lot of spaces in the abdominal wall where we can place the mesh, either by the open surgical method or the laparoscopic surgical method. These potential spaces, they have to be opened up, they have to be dissected, and a mesh to be placed. So various terms which are being used for mesh placement could be an onlay mesh, inlay mesh, a sublay or underlay mesh, pre-peritoneal or intraperitoneal. I'll be telling this one by one. Only mesh placement. Only mesh placement, we say when we place the mesh on the muscle. So it is over the muscle, below the subcutaneous fat. Just to demonstrate what you mean by an onlay mesh. So here we can see that a space is being created between the subcutaneous fat and the external oblique muscle. This space is being created. It can be created by open method or by the laparoscopic method. Here what we are demonstrating is the Scola technique, where a laparoscopic method is being used to create this space. Now this space is being created and the hernia is being taken care of, wherein we are closing the defect of the hernia by using a suture. We measure the mesh required for this defect, and here now we are placing the mesh in an only fashion. So here the mesh is being placed on the muscles and the mesh is being fixed. Inlay mesh repair. In inlay mesh repair, what we do is we place the mesh between the rectus muscle and the anterior aponeurosis. This mesh is being placed between the rectus muscle and this aponeurosis. In sublay, we place the mesh below the rectus muscle. So it is between the rectus muscle and the posterior sheath. So I would like to show you a video which will show how to open these planes and how do we place a rectorectus muscle. The procedure being shown here is a Taru procedure where there is a small umbilical defect is there and the plane are being opened. Here we can say that the PSR complex, that is the posterior sheath and the peritoneum complex, they are being reflected down and a space is being created between the rectus muscle and the posterior rectus sheath. A little difficult part during this dissection and during this surgery is the crossover, where you have to cross at the linea alba onto the opposite side. We don't want to break the structures or disintegrate the structures of the linea alba. So the linea alba has to be always there on the roof and it is not disrupted. now we can see that we are entering onto the opposite side between the rectus muscle and the posterior rectus sheath, and this space is being created. So this is the retrorectus space where the meshes will be placed. Now we are closing the defect and we are placing a mesh in the retrorectus space. So this PSR complex is now closed by using a suture. Now comes the intraperitoneal mesh placement. Usually by the development of the laparoscopic surgery, this intraperitoneal mesh placement has become a very popular choice, even for the incisional hernias and the ventral hernias. They have become a very popular choice where the mesh is being placed intraperitoneally over the peritoneum. The question was asked to me in a previous talk that when do you use a biological mesh or a dual mesh? So this is the space where the mesh will be in contact with the intra-abdominal contents. So here you are going to use a dual mesh so that it doesn't get adheres to the mesh. So again, the concept is the same. So first we are going to reduce the contents of the hernia. All the contents have to be brought down, and it has to be done very gradually, very slowly, so that you don't injure the contents. If the content is an intestine, we have to take extra precautions so that there is no entrotomy, there is no injury. If there is an entrotomy, then it is very difficult to place a mesh. First, the contents are brought down, and then the fat has to be brought down, because this fat will not allow the mesh to adhere to the intraperitoneal part of the abdomen. So this fat has also to be brought down so that we have a good surface where we can place in the mesh. Now we can see that the contents are reduced and we have also removed the fat. The defect is now being closed. And we place a mesh. Now this is a dual mesh where we have a polypropylene surface which is in contact with the peritoneum, and it is got an inner surface, which this inner surface it may be made up of cellulose or some porcine derivative, which will not allow the intestine to become adherent. So after placement of the mesh, we can see that it has been fixed by tackers, and it's a dual mesh being.
Please take.
Another method is the anterior component separation. Now, if we have a large defects, usually laparoscopic surgeries, they can tackle up to a 5 centimeter defects easily by this IPOM or IPOM plus method. But if we are having a large defects which are more than 5 centimeters, if there are large incisional hernias, then we need some methods to close these incisions in the midline without creating any tension. And another concept is that the repairing the anatomical repair, we should also give a physiological repair to the patient. And physiology of the anterior abdominal wall, it will depend upon the rectus muscle being in the midline rather than on the lateral aspect. So if you're using any bridging meshes, then that will not bring the rectus muscle into the midline. So to restore the physiology and to bring the rectus muscle in the midline, we need to dissect laterally and bring the rectus muscle in the mid. There are two methods prescribed for it. One is the anterior component separation, another is the posterior component separation. In the anterior component separation, we give an incision on the external oblique aponeurosis. It is about 1 to 2 centimeter just lateral to the linea semilunaris, and the fascia is released to attain the primary closure. It can give an up to a 7 centimeter advancement on both the sides, and the rectus muscle is brought to the midline. Actually, we don't practice much of the anterior component separation, so I'll be showing you a more of a theoretical video, but you'll be better able to understand what do we mean by an anterior component separation. Herein, we are again separating the layers between the external oblique sheath and the anterior abdominal wall. After the separation of this external oblique muscle just lateral to the rectus abdominis, just lateral to the rectus abdominis, and this lateral to the linea semilunaris, we are giving an incision over the aponeurosis of the external oblique muscle, which you can very well see in this video. There is a division of the external oblique aponeurosis. This division of external oblique aponeurosis, it will help us to medialize the rectus muscle. We are dissecting it both cranial and caudal fashion. This external oblique muscle is being seen. So now we have a lot of space to place a bigger mesh, and the rectal muscle, it is lying in the midline. The same procedure is done on the contralateral side also. So that will give you another mobilization of 5 to 7 centimeter, and we have beautifully closed the defect in the midline. So this is going to restore the physiology of the anterior abdominal wall. The another method for it is the posterior component separation or the transverse abdominis release. In this method, what we are doing is we are releasing the transverse abdominis muscle and we are pulling the rectus muscle in the midline. So this will avoid the disruption of the nerves and blood supply. And to avoid this, we have to give an incision on the fibers of the transverse abdominis muscle. So as we have already seen that the junction of the muscle with the aponeurosis is at a variable level in the abdominal wall. So it is more fleshy cranially and caudally. So it's always easier to start either cranially where there is a fleshy fibers or caudally where there are certain fleshy fibers, and it is easier to identify the fascia transversalis muscle. So if we are having large hernias like this, incisional hernias, which are very difficult and there is maybe a loss of domain in such type of hernias. So in some sort of component separation has to be done in this hernia. We first reduce the contents of the hernia. We place certain sponge or sheet just to avoid any injury to the gut. And here we are giving an incision on the posterior side of the rectus muscle, posterior rectus. So that is the difference between the anterior component and the posterior component. We saw that in anterior component incision was given anterior to the rectus muscle. Here we are giving an incision on the posterior part. Posterior to the rectus muscle is being incised, and now we are gradually separating the transverse abdominis muscle. This separation of the transverse abdominis muscle, it will give a pull and will be able to easily bring the posterior component in the midline without any tension. This is a very potential space and we can create a lot of space in this plane. Even large meshes like 30 by 30 centimeter mesh, they can be very easily placed. You can see that there is a lot of space and we can in fact easily create space up to the anterior axillary line. That's very easy in this plane. So a large mesh can be placed using this method. Up to a 30 by 30 centimeter mesh, this mesh is cut into a hexagonal shape to fit into the shape of the abdominal cavity, and whole of the abdominal cavity is covered by this mesh. After placing the mesh, we can always suture the midline again and close the skin and put in a drain. There could be a lot of seroma formation because there is a lot of dissection going on in this type of repair. So abdominal drain is preferred over it. So these are the various methods by which we can close the anterior abdominal wall. And knowing the anatomy, the various planes of the anterior abdominal wall will tell us which plane to be used for placement of such complex hernias. I think the anterior abdominal wall is a very complex structure. Understanding the various layers and placement of neurovascular bundle is very crucial in the hernia repair. And surgery is nothing but knowing and dissecting the natural planes which the God has created us to be opened up. Thank you.
Wonderful lecture, Dr. Shireesh, on the anterior abdominal wall anatomy and the various planes of the which we can use in the ventral hernia repair. I want to ask 2-3 things that which plane do you feel is the most suitable for ventral hernia repair? Primary ventral hernia repair is small size, like 4-5 centimeters, and bigger hernias like 8 to 10 centimeters defect.
Well, sir, to my personal choice, I feel that the retrorectus plane, it's a very good plane. It gives a lot of space can be created for 5 centimeter hernia. We can always dissect it up to the border of the rectus muscle, and we can place in a 15 by 15 centimeter mesh over it very easily. And the mesh is not exposed to the intra-abdominal content, as well as what you have already told, that the Pascal's law, wherein this placing a mesh below below the defect, it will help in reducing the recurrence. So a retrorectus space would be good. If it is a bigger hernia, more than 5 centimeter hernia, we'll need to place a bigger mesh, a 20 by 20 centimeter mesh. Then definitely we have to dissect more. And in that case, I would like to go for a posterior component separation in this case.
And why not anterior component separation?
Anterior component separation, I think it has the potential of damaging the neurovascular bundle, which is entering into the subcutaneous plane above the rectus muscle where there are perforator branches. So that could be disturbed. Secondly is again the anterior component separation. It is little different from what the Pascal's law tells, because here you are placing a mesh which is above the defect.
Only.
It's a sort of only. Sort of only.
Not exactly only, but sort of only. And it causes there's a chances of SSO, not SSI, SSO, because of vascular compromise. There is skin necrosis or seroma, large amount of seroma collection, because there is no pressure over this.
Yes,
in posterior repair, there is less chances of seroma. There are chances, but there are lesser chances of as compared to anterior component. So that's why we use usually bigger hernias, posterior repair, that is transverse abdominal release. Basically, TAR, posterior component separation, based on a principle that we used to study when our anatomy days, that transverse abdominal muscle is aponeurotic beyond the linea semilunus towards the medial aspect, midline. But now we have come to know that transverse abdominis muscle extends about 1 to 2 centimeter beyond the linea semilunus. That gives an advantage of cutting that this transverse abdominis, causing TAR to have a posterior component separation. Very well.
And a big space can be created over there. Almost a potential space. We can go up to the anterior axillary line and even up to the mid axillary line, but usually we don't need such a big space.
You can go up to the psoas muscle.
Up to the,
you can see the ureterus from there.
It's an unlimited space.
It's unlimited. It's a huge potential space.
It's a huge potential space.
And what about neurovascular bundles?
Well, neurovascular bundles, that has to be preserved, and to the method to preserve it, that you always give an incision which is little lateral to the linea semilunarius, so that you don't disturb the neurovascular bundle. As I've told you, that try to enter it either cranially or caudally, where you have a fleshy part of the muscle. So it will give you a better plane, and that is going to preserve the neurovascular bundle.
There are 4 to 5 neurovascular bundles from subcostal margin up till the iliac crest. They say that you can sacrifice one neurovascular bundle, there will be no harm. At the most, you can sacrifice two neurovascular bundle. There is just little weakness. But if you have sacrificed 3 neurovascular bundle, then it's a disaster for the patient.
Yeah.
Dr. Abadhesh.
It's a wonderful presentation. I want to add something. That the component separation technique aids in the abdominal reconstruction for the large complex hernias or for the patient with the loss of domain. Especially in that cases, the principle of the abdominal reconstruction is to close the defect. That must be tension free, and there must be medialization of the abdominal anterior abdominal muscles. Okay, so the normal physiology of the function, as was said, that is the breathing, defecation, vomiting, and urination, that has not should be compromised in these patients. So there should not be any recurrence of the hernia to prevent that. So that we have to close with the tension free. We have to do either the loss of domain, we have to do the Poche component separations with the TAR, unilateral or bilateral according to the defect size. Then after closing the defect, you put the mesh when you are facing some problem with the closing in the anterior seam. Anterior component you are not able to close that, then in that cases you have to do the anterior component separations. You have to lateralize the external oblique muscle laterally, by the unilaterally or bilaterally, then close the defect. In some cases, when the defect is large or there you are not anticipating that or there is a limiting in the anticipation that the posterior component is not enough to close that defect. Then in that cases you can use the free peritoneal flap to close the posterior component, then we put the mesh and then do the anterior component and close that defect. So in abdominal reconstruction, we have to take care of all these. And second thing is loss of domain. In loss of domain cases, you have to be very careful. You should do the CT scan. You do a measure of the defect size. Because the defect size you are anticipating from externally outside that is larger, but intraperitoneally that is small. Then you have to be anticipate around a 3 centimeter defect can be, you can adjust according to your surgery. Because there is defect is size large, or is a new classification is there for the loss of domain or the incisional hernia, as video said. There is a new classification is the bulge. They are not saying that is the incisional hernia. They are currently yes, they are saying this is the bulging of the sac. Okay, there is no well-formed sac, only there is a bulging. In that cases, you have to take care of that. You may need pre-peritoneal flap mobilization. You have to cover the defect, place the mesh. You have to medialize the rectus muscles medially by either the posterior component or anterior component with combined procedure. Then we have to close that defect.
This is one thing you have said that if after doing posterior component separation and you are not able to close the anterior sheath, you can do the anterior component separation. That is not the case. You can't do anterior component as well as posterior component separation in a single patient. Despite posterior component separation, if you are not able to close, you can use the peritoneal flap technique, very well said by you. And second thing, even if you don't preserve the peritoneum or peritoneum is not there, you are not looking, peritoneum is not looking healthy, then only option left with you is to have a bridging repair. That is, you need to place a dual layer mesh or the vicryl mesh, and then you put the prolene mesh over that.
I'm asking about the anterior sheath closure. I'm anterior component separation is a part of anterior sheath closure. Not we are putting mesh over anterior sheath or on the mesh.
No, but if you have done posterior component separation, then you can't cut two muscles in a single patient.
PCS with either unilateral, bilateral, I have closed that defect, okay, without mesh closure. But when closing the defect anteriorly, anterior is wide open. Okay, there is we have to medialize the rectus muscle. We have to give the release incision.
No.
Yes,
That is not at all recommended. Anterior component separation cannot be combined with you cannot sacrifice two muscles in a single patient. You have sacrificed transverse abdominis, you can't sacrifice now external oblique muscle. You have to take some other precautions. You have to take peritoneal flap or whatever you can say.
Not only the covering of the defect, I think medialization of the rectus muscle is different. Okay, that by that you cannot medialize it.
And one question from the audience. I just want to say, suppose if something happens that we sacrifice 3 neurovascular bundles, then how to manage that patient? Is it possible to do something for or lifelong crippling is there?
Yeah, definitely, if you have damage the neurovascular bundle, there will be atrophy of the muscle,
possible sometimes.
weakness later on.
And the defect is there, so patient will be crippled. So this is a procedure to be done by
experts. Is already compromised, then there is the separation of the recti muscle, there is the atrophy of the muscle because in previous surgery because of infection or because of underlying
constipation defect.
There is already atrophy of the muscle that causes the separation of the muscles and recti muscle. So you have to take care of that.
Actually, the
One has to
physiology
be
will
careful,
be,
yes.
physiology
Physiology will be
is,
disturbed.
that is disturbed.
So this is a double sword, means we have to work very carefully. These procedures should be restricted for those of domain or
Two quick questions. Small umbilical, paraumbilical, or incisional hernia, small defect. Can we do an anatomical closure or should we always put a mesh?
Sir, if it is 1 centimeter defect, then I would go for an anatomical. Anything above 1 centimeter, then I would like to place in a mesh. Mesh placement in the various layers, that could be a choice, open or a laparoscopic, what we are well versed with. Any defect more than 1 centimeter, I would like to place in.
Second, incisional hernia, but a very large defect. Now, it's not possible to close that defect. Then what do you do?
So if there is a loss of domain, we are not able to close it, then we must try to first increase the space in the abdominal cavity. Various methods are available where we can increase the cavity size by using a balloon, by using a botulinum.
It's not loss of domain. The sac is small, but the defect is big. So you have reduced the contents. There is no increase in intra-abdominal pressure, but you can't close the defect. So can we still place the mesh and leave the defect? Any precautions? Because that will form a seroma then.
No, well, sir, posterior component separation has given us a huge advantage, and we are able to close most of the defects. And if you are anticipating that it will be difficult, we must try to preserve the sac of the hernia, because that sac can be used as a layer over which we can place in a mesh. So that way we will be able to cover the defect and we'll be able to put in a mesh. Good side is just mesh.
What about plication of the sac to reduce the space where a seroma can form? Would you recommend that?
So usually in this large incisional hernia, the sac is very difficult to preserve. Most of the time it is excised during dissection. So if you are anticipating a big defect, you must be very cautious and try to preserve some part of the peritoneum. So plication is, I don't think it will be needed, because anyway it will not be there during the completion. As you have seen in the video, you mostly the peritoneal sac is excised during the dissection of these incisional hernias.
Concept of the IPOM plus came because of that, because in IPOM plane that was tension free, that was good, but there the chances of seroma formation, mass bulge was there, so the concept of IPOM plus was there, and recurrence rate are almost same. But these complications, as you said, the seroma, mass bulge can be avoided by the doing IPOM plus technique.
But you're all hernia experts. IPOM, isn't it a misnomer? It's not onlay.
So I would like to add one more thing that we have already shown. I've shown a video of Scola where we are placing a mesh, only mesh. But I've seen in my experiences, there is a lot of seroma formation in such cases. There is a lot of cautery being used, a lot of dissection being done. In fact, I have done a few cases of Scola and now we have abandoned. So placing an only mesh is not my choice nowadays.
Sir, one comment about peritoneal flap. What we do in large sac hernias, maybe defect maybe 6, 7, 8 centimeters only, but sac is huge. So we preserve the peritoneum and lateralize, medialize the both the muscles by doing unilateral or bilateral TAR. Even if still then we are not able to close the posterior rectal sheath, then we use the peritoneal flap as a covering over the in this bowel contents. Okay, we do midline incision on the peritoneum. One peritoneum left is left on the left side and one is on the right side. One peritoneum goes with the posterior rectus sheath and one peritoneal goes with the anterior rectus sheath. And between these two peritoneal layers, we put a mesh. That is a sandwich technique. That is a wonderful, producing wonderful result. Even without TAR, you can do big hernias with this peritoneal flap technique.
I think that is going to answer the question which Dr. Abadhesh has raised. We are preserving the peritoneum on both the sides.
But only covering the only covering with the mesh without medialization of the recti is not recommended.
Yeah, okay. Yeah, definitely it will not.
In previous era, you do only by plicating there, put a mesh. I have done the hernia. That is not the principle of hernia, doing hernia surgery, I think.
So what is your take on routine drain placement when we are putting a mesh?
Well, if I have done less dissection, not much dissection is done, cautery is not used much, then I would not like to place a drain. Rather, I would just like to strap the abdominal wall. That will take care of. But if you are using a method like Scola, where a lot of dissection is done, a lot of cautery is being used, then I would like to place a drain.
When we started the ETAP RS or TAR in previous time of 2018 and 19, we used to put the 4 in open hernias to retrorectus, to subcutaneous. There was zero formation, but now we have abandoned that, stopped that. There is in open hernia there is chances of seroma there, but that can be conservatively managed.
Okay, I think we'll have a group photograph and then we'll break for tea and come back at 11:20.